Welcome to this video on stroke and TIA in the emergency department. We will explore a tissue-based framework for recognition, risk stratification, and making informed reperfusion decisions.
In this session, we will cover how to reclassify ischemic events, exclude common mimics, risk stratify patients, drive the reperfusion pathway, manage patients medically, and define the scope of the emergency physician. Let's begin by discussing a new framework for understanding ischemic brain events. We can improve our approach by borrowing from the ACS spectrum. Instead of relying on arbitrary time cutoffs, we should classify ischemic brain events based on whether imaging confirms a completed infarct. This approach creates three tiers: stroke, representing permanent deficit; transient symptoms with infarct, where symptoms resolve but imaging shows an ischemic core; and TIA, where symptoms resolve with no infarct. Next, we will focus on recognition and identifying important stroke mimics. The first 5 minutes are crucial. Always check glucose immediately, establish the last known well time, use a validated screening tool, and activate the stroke pathway early without waiting for a full history. Be sure to consider these 4 mimics: hypoglycemia, which can cause focal deficits; Bell's palsy, if the forehead is involved; giant cell arteritis; and aortic dissection. Now, let's turn our attention to risk stratification. The ABCD squared score is a bedside tool that estimates short-term stroke risk by evaluating age, blood pressure, clinical features, duration, and diabetes. Remember that a low ABCD squared score does not guarantee safety. Vessel imaging remains essential because high-risk findings, such as severe carotid stenosis, require urgent identification. Finally, we will outline the recommended imaging pathway. The process typically starts with a non-contrast CT, followed by CTA of the head and neck, and potentially MRI DWI. We also use the aspect score to evaluate early ischemic changes. This section reviews current reperfusion therapies. Modern stroke care prioritizes identifying salvageable tissue, whether using standard IV thrombolysis or imaging-selected approaches for extended windows. Confirm criteria with your institutional protocol. When selecting candidates for endovascular therapy, look for a large vessel occlusion, a small ischemic core, a salvageable penumbra, and evidence of adequate collateral flow. Moving on to secondary prevention and medical management. For antiplatelet therapy, aspirin is the standard first-line treatment. Use dual antiplatelet therapy only as a shared decision for high-risk patients, keeping in mind the increased bleeding risk. Anticoagulation is vital for patients with atrial fibrillation, mechanical heart valves, or LVADs. However, strictly avoid it in cases of active infective endocarditis or aortic dissection. Manage blood pressure carefully. Avoid aggressive lowering in non-reperfusion candidates, as permissive hypertension helps preserve the penumbra. Tighter targets apply only after reperfusion therapy. In closing, remember these pearls: check glucose, document time, and activate your pathway early. Don't assume symptoms are just a TIA or aggressively lower blood pressure before checking the protocol. To summarize, think in tissue rather than time. Always exclude mimics, use imaging to guide your decisions, and match your therapeutic approach to the specific underlying mechanism of the stroke. Thank you for watching. Please ensure you refer to your local institutional protocols and current guidelines for the most accurate and up-to-date stroke management practices.